Time now for this week's Health Matters. Paul Critz with you, along with PA Lynn Szabo. And we're talking strokes, but that's not what they're called, right?
Yeah, it's not what medical people call them. We have our own language.
Wait, what are they called? What do you call them?
This is mostly CVA, which means Cerebrovascular Accident.
Accident.
Which I think is funny because it makes it sound like, oops, I blew my brain out.
Whoops.
Didn't see that coming.
Heads up. Oh, no. So an accident, that's interesting. I guess, I mean, just the term, is a heart attack an accident? I guess it could be, sure.
No, it's a myocardial infarction.
So an infarction,
Yeah.
why doesn't it get the why is this an accident?
I don't know.
Okay.
I don't know.
All right.
But, I've always thought it was weird.
That is weird.
Yeah.
So-
But what it's really defined as is a neurologic deficit, so a problem with the central neurologic system lasting more than 24 hours. So,
Okay, regardless of cause?
right.
Interesting.
Yeah,
Okay.
so that's an umbrella statement like so many things in medicine. And then when you kind of break it down to the component parts, it goes in this direction or that direction.
Wow, okay.
Yeah, but it always has a cerebral, that means brain, vascular cause. So, but there's two main types and there's kind of a warning type. So there's ischemic, which means a compromised blood supply to the brain for some reason. Okay. There's hemorrhagic, which means an actual bleed into the brain. And then there's a TIA, which is kind of a warning shot over the bow, like something's about to happen. But it kind of happens and then it retreats and people go back into normal function.
Wow, okay.
Yeah. So let's talk about ischemic first. So this means compromised blood supply to the brain for some reason. And the symptoms are usually partial or loss of strength in an extremity. But people can also use their ability to use language. Remember, there's two parts to that. There's understanding what people tell you, and then there's being able to respond appropriately.
Right.
So receptive and expressive. Loss of vision, okay, usually on one side, or part of both sides. So not necessarily total blindness, but kind of in a pattern. And we can tell from the pattern what part of the brain is affected. So
Right.
that's kind of cool.
That is cool.
That's a board question. And then there's risk factors. So people who are at risk for ischemic stroke or compromised blood supply to the brain stroke, they have a personal history of previous stroke, a family history of similar stroke, high blood pressure. This is why they call high blood pressure the silent killer. You kind of don't know you have it until it takes something vital out. Elevated cholesterol, which is probably all of Del Norte, diabetes, atrial fibrillation, which means an irregular pattern to the way the heart beats, and so little blood clots get thrown into this very delicate vascular system in the brain, and then they clog, part of the
Right, because
system.
that's what ischemic is. It's
Right.
I mean, it's like a blockage of some
It's
sort.
like a clog, yeah.
Okay.
Sickle cell, people who have this are, their blood cells are weirdly shaped and they are a little bit sticky. And so they get ischemic crises all the time, but they're also at high risk for actually having a stroke. And then people with carotid artery problems, which, is usually irregular surface on the inside of the arteries that feed into the brain, and either plaque breaks off or a little clot forms because of the
okay.
irregular surface.
Okay.
And then sometimes people have a change in their vision where they lose sight in one eye. We have a friend who went through this in the last couple of years.
Yeah.
Yeah.
Wow.
So super complicated. And then, of course, the second kind is hemorrhagic, which is actual bleeding into the brain. And you have similar symptoms and risk factors, but hemorrhagic strokes are also caused by people who have problems clotting their blood or who are taking medication for some reason that makes their blood hard to clot.
Right.
So ironically, somebody could have an ischemic stroke where a clot was thrown by irregular rhythm of the heart,
And their treatment.
get
Yeah.
put on blood thinners,
Right.
and then suffer a hemorrhagic stroke.
Oh my gosh.
Okay.
Wow. Okay.
But the newer blood thinners are actually pretty safe to take, and we don't have the wild swings and hard to control problems we've had in the past.
So does a hemorrhagic stroke, the bleeding involved? I mean, is that something that can happen? Obviously, because it seems like because something in the blood, the nature of the blood and its ability to clot. But how does does the bleeding need a hemorrhagic stroke or bleeding event in the brain? Does it need some sort of damage to a vessel, or is it just something that can happen because the blood is different? Does that make sense?
It can both. So sickle cell's an example of
Right.
something that might happen. That's ischemic, though, but that the blood is different. But let's say somebody has hemophilia. Mm-hmm. Let's say you're
Right.
the real last Tsar of Russia and you have hemophilia. Then that makes your blood clot abnormally. Mm-hmm. And then you could cause a bleed in the brain. Maybe one of the vessels has kind of what's called an aneurysm, which is like a bleb in a tire. And it just blows it out,
Yeah.
and then you don't stop bleeding in a normal way.
Right.
So yeah, you can,
I'm curious as to how having blood clotting or anti-clotting, if you're dealing with I guess that's the same sort of thing. You'd need to hit something like an aneurysm. And I mean, it's just not something that's going to happen in sort of the normal structure of the vascular system of the brain.
yeah, I think it could.
Okay.
I think it could. There could be like I've seen in my career somebody who had a virus, and he dropped the number of platelets he had to very scary levels. And so he could have just seeped out.
Yeah, that's
And
what I
not
was.
necessarily had an aneurysm with a central blow.
Right,
He
right.
could have just seeped out. And that's actually how it presented, was he was peeing blood.
Oh.
Now, some people think they're peeing blood and it's really beets or something, but this guy had an alarming deficit of platelets
Yeah.
because of a viral syndrome that he had. Took a hit on his bone marrow. So he got a cold. His bone marrow was affected by this virus. And then he started oozing blood from everywhere.
Oh my God.
I know. Blood clotting is actually kind of a fascinating thing.
Yeah,
It's
yeah.
super complicated, and the screw-ups could happen anywhere along the line.
Hey, I want to request if we can do some sort of just a informational episode at some point, just about blood in general. Blood is I've got questions just following along after that person's scenario, that one patient
Right.
scenario about it. So if you lose the platelets, does that mean that your blood is mostly plasma at that time, or is that, the makeup of blood? And this could be, we could pass this down the line.
Right, I think that's what happened to him. He was taken out of my care in a hot second and put in under the care of a subspecialty
Wow.
hematologist. So he was hospitalized and his head was sandbagged.
My God,
So because
really?
they didn't want him moving it, they didn't even want him sitting up.
Just chill
Yeah.
while we get this addressed. Oh my
Yeah.
gosh. Wow. Okay. All right.
But
That's
you
just-
could also take a lot of aspirin because you're a little lady with arthritis,
And
and
it thins you.
aspirin makes platelets not stick together well. Platelets are the cells that clot blood,
Right.
or
which is why you take the aspirin, right?
right. Well, kind of. Some people grew up taking aspirin for pain, so you have joint pain. A lot of elders take aspirin instead of all this newfangled stuff.
Oh yeah. No, I just meant
Yeah.
that kind of daily prophylactic aspirin that people were
Yeah,
told
that's
to take.
different. That's
Yeah.
for people that might have risk for MI or ischemic stroke.
Okay, there you go. See?
Yeah,
All
there you
right.
go. So it's super cool.
We're right back where we started.
Anyway, it's super complicated, and you can go kind of to both ends of the extreme, and neither of those places are good.
And a lot of the you've under the listing here for in your notes for the hemorrhagic strokes, it's the same risk factors too, right?
Same exact risk factors, but I would add on things that can cause blood clotting problems, or an aneurysm, which is kind of a bleb in one of the vessels.
Yeah.
And it's, sometimes you get warnings that things are going to happen, and sometimes they happen, just cataclysmically, like all of a sudden, one and done. And I would say that it's not uncommon, actually, to have a stroke and to just drop dead from it.
Right.
And where you don't get a chance to, medicine doesn't get a chance to intervene and see if they can help somebody. And this, if you got a room full of physicians and asked them what their worst case scenario, that would be something like that.
What, stroke?
Yeah.
Wow.
Stroke is their worst case scenario. Partially
You mean
because,
personally for them? Like,
Yeah.
that's what they don't want? Okay.
Oh,
okay,
God,
yeah.
that's what gives them the creeps.
Because it's just like being hit by an asteroid or something, right? You don't see it coming and boom.
Or even worse, it could halfway come.
Oh,
And then
right.
you're debilitated. And especially frustrating for people who have movement difficulties, super common after stroke, or speech difficulties. And if you know doctors, they like to talk. Maybe not to patients, but to other people.
I don't know what happened, doctor. Your handwriting's atrocious.
Yeah.
So, any idea how many people in the United States have strokes every year?
Oh, God. I decided not to look that up, but
I
it's
am right
super
now.
common. So,
Oh, there's a whole site. It's called Stroke Facts. I don't want to click on it. No, it's from the center. It's from the CDC.
is it scary? A lot of people.
A lot of people.
I would venture to say every middle-aged person in Delaware County knows somebody who's had a stroke. Or you've
Really?
been to Safeway and you've seen somebody who's got residual problems because
Wow.
of stroke.
Huh.
So,
1 in 6 deaths in 2022 from 1 in 6 deaths from 2022 from cardiovascular disease was due to stroke. So that's a subset of a subset.
yeah,
So,
and that's
yeah.
what kills Americans, actually, is cardiovascular / stroke.
The most. Yeah.
Yeah, most of us. But sometimes you get a little period of grace and you get a mini stroke. And so mini stroke is called a transient ischemic accident.
That's the TIA. Oh, I get you. Okay.
TIA.
What are those like?
So those are like somebody could get maybe a change in their ability to talk or understand what's going around, but it's only temporary. And then some people get weakness and numbness in an arm, but it's only temporary.
Right, okay.
And it might actually come and go before people choose to pay attention to it, which is a big mistake.
What is?
This is the whole take-home message of my discussion.
Oh, here it
today.
is. Listen up.
Here it is. If the nurse tells you to go to the ER because you're having these kind of symptoms, then don't say, well, it's kind of stopped for now and I'm just going to wait and see.
Is there a way, let's just say you're, I don't know, a male in his late 50s and you're sitting around and you don't bother to involve a nurse. Is there a way for for this prospective patient to recognize a TIA when they experience them?
Yeah. So problems talking, problems thinking, problems in movement that are really focal. That means located in one extremity, perhaps. Problems with numbness, problems with vision. That should scare people. That's abnormal, and somebody should seek care.
And you're saying like more than just that happens every day.
Yeah.
Like it's going to be a pronounced sort of thing that you notice.
Right.
Okay, gotcha.
It's going to
gotcha.
be
'Cause
your.
I have problems thinking all day
usually-
long. That's what I'm.
No, that's hypochondria.
Is that what that? Okay, all right, thanks.
Anyway,
And we've had an episode.
yeah,
about
we
that.
talked about that. That was well received. Anyway, so it's going to be. I think a lot of times when people have something scary that happens in their, and it moves them from homeostasis in their body, that means their set balance point. Then the first hope is that it's going to go away in a couple minutes and you don't have to think about it.
Right.
Right.
And these do go away, right?
These do go away after about an hour.
Oh, okay.
But
okay,
less than
okay.
24 hours. But that's, you've just blown a golden opportunity. So that is a moment in time where you could, if you access care at the ER, and let's say you were able to prevent a catastrophic stroke a little bit further down the line and maintain normal function, then that's what we want in healthcare. And if you go to the ER and they're like, I don't know, maybe it's indigestion. They do a workup on you and an exam on you and arrive at another conclusion that's benign. That's the desired outcome.
Right.
That means they have ruled out badness. And so, and it kind of doesn't matter whether you like the ER or not, or they make you wait or not. And what matters is the devastation after a stroke is is a lot for somebody to bear. The functional abnormalities are, people struggle day to day, and sometimes they're able to get certain abilities back, like their ability to speak, and sometimes they're not, and it's kind of heartbreaking. And then there's a big role of depression, and it just challenges people's lives on every level.
Right.
So if it occurs to you that it might be happening to you, then do something about it. This is the biggest argument I think the triage nurses have that I hear in the clinic. By the way, I'm on the other side of the phone. The nurse is speaking, but I'm like firing questions at them and stuff. It's the weirdest thing. Like, why don't I just take the phone call?
I know, right? No,
I know. But if somebody suggests that you go to the ER and you're having symptoms like this, go to the ER. Because even in Del Norte, we're actually able to do something about this. And most of the time, people that are actually having a stroke, and they can tell pretty quickly whether it's ischemic and somebody needs to go on blood thinners or maybe have a clot removed from somewhere, or whether it's hemorrhagic and, they have to do other things to, to control the damage. There's something called a golden hour, and we talk about this in medicine with regards to trauma, but it also applies to stroke. There really is something within, very early on, within an hour or so, where somebody could actually have meaningful intervention that saves them from lifelong misery or death.
I get lost in the possibility of being alone in a situation and not recognizing it for what it was. There was the first time I ever got one of the ocular migraines, right? I thought that was a stroke.
Right.
But, I didn't jump up because it didn't hurt. It was a weird sort of thing in my vision. And by the time it became concerning, it was lessening already. And then I followed that home back to normality. But
I too get ocular migraines, and I remember the first one that I had, and I happened to have gone to a talk by a neurologist in Humboldt County who's a migraineur himself. And he said, anything that lasts less than 20 minutes is probably okay to put up with, but seek care eventually. Anything that's over 20 minutes, you should probably seek emerging care.
Wow, okay, that's interesting.
This is just, I think, reasonable advice.
It's like highly informed, anecdotal. Yeah.
And so what was your experience with the timing of your ocular migraines?
Oh, gosh, I don't know. It was 25 years ago the first time. But yeah, I gave it, it got, the flashing starts and then the chain grows around the edge of my vision. And that maybe took about 5 minutes. And I was very freaking out and feeling very strange. And then it started lessening and I calmed down.
And then you had oftentimes you have a boomer of the headache after that.
No, I never did.
That's my experience.
Wow.
But yeah, the same thing. It kind of looks as that semi-lunate or half moon shape. It gets bigger. It kind of in the center looks like what a window in a car would look like if it had rain on it.
Oh, wow.
Like really blurred.
Okay.
Kind of like a blurry watercolor. So, something with my experience at like 19 and a half minutes, I was driving on 299. So I was going, do I pull over and die out here?
Oh, my
God.
God.
Do I go over? I wait, I try to make a run for it and go over sometimes one
hope
knows
you can coast
too
down
much.
into Arcata.
Yeah, I was right by where that hydraulic scar is from hydraulic mining. And that's pretty remote. So anyway, I decided to time it, pull over, time it, see how it went. And at like 19 and a half minutes, it went away.
Wow.
Yeah.
Wow.
So, yes, that's a different thing. But what if somebody went to the ER with those symptoms and got seen? They could sort that out pretty quickly. And if they said, oh, this is just an ocular migraine, I know it's scary. This is the way you treat it for now and then get into your provider. What a relief that would be.
Sure.
Yeah.
Sure. But the realities, I live in Del Norte, and a trip to the emergency room costs at the very least $1,000 for me.
And
so no, I'll sit and look at the flashing lights for a while.
Yeah. Up to 20 minutes is in my situation.
Okay.
That's information I thought was useful. But what they do is if you're actually having a stroke, then they fly you out to Reading, where you can have what they call.
We have the stroke in the valley, right? Is that what?
No, they have a stroke center in Reading. This is
okay.
actually something that kind of works right up here. And they can do an embolectomy, which is where they take a clot out. And they can get within those golden hour and then golden hours. So
Wow, okay.
And they can minimize the amount of damage and then reverse it and then prevent it. Because then you get, let's say you get flown out to Reading, they're able to do an intervention that really, really helps you. And then you go back, you're stabilized, and then you go back to your primary care person to talk about prevention. So how do you fix the underlying problem? Because as people have figured out, it depends on what kind of stroke you had and what actually caused it. And so you address it more directly in a preventative sense.
Right.
Does that make
But a
sense?
lot of the risk factors are the same. So
Yeah,
there are a
it's-
lot of things you can address across the board.
Yeah, I feel like I'm saying all the same things. All of a sudden, there's like rules for living right. Are you guys getting the pattern yet? So work on lowering your cholesterol, and in most neurologists' worldview, that means taking a statin, which does not deserve the negative lay press that it gets.
That's what you said. Statins are foundational in
They are
in medicine. Yeah.
foundational, and they are not scary. And just because one person in a million gets a certain result that's temporary, minor, and reversible doesn't mean that everybody gets it,
Right.
or that you're going to get
And
it.
you said before on the show that even doctors, healthcare professionals, take statins just prophylactically and for other things, right?
Yeah, they do.
Yeah.
They're convinced by the data. Blood pressure, keep your blood pressure under control. So that's like DASH diet, which is very similar to the Blue Zone diet that we've talked about, or the Mediterranean diet, or take the medicines that you're supposed to be on. And if they don't seem to be working for you in a way, then work with your provider to try another kind. There's lots of different blood pressure medicines and lots of different categories working in different ways. You can find your solution. Stop smoking, which, Great American Smokeout coming up on the 17th of November, I think. Get the diagnostics that are ordered. So somebody may order an echocardiogram, which is like an ultrasound of your heart to see if you have clots in your heart because of irregular heart rate or something. That's hard to do in this county, but follow through and get it done.
My wife has had to take a referral down to McKinleyville or Arcata. I forget where she had to
Right.
go for an echocardiogram.
Right.
Yes.
Or do an ultrasound of the carotids. That's what our friend did, and he ended up with surgery.
Yeah.
Yeah. And if surgery is recommended, consider it seriously and don't say, well, that sounds kind of scary. I don't want to do that. Because, you got to fix the underlying problem or this is going to come around and it could be worse the next time.
Wow.
So know your symptoms and understand this clearly. You have a limited amount of time to reverse the problem. So go to the emergency room early and don't argue with the nurse who's trying to get you to go there, which is oftentimes just me with a different voice. Or, or the provider. That just kills me. But anyway.
Let's go over, if we can, the signs to look out for again. Because again, that's where I'm stuck. I'm stuck on that frontier as a person sitting around experiencing something. Because I've done that. Every week something happens and I'm like, oh my God, this is it, and then and then it's not. So
right.
Let's run down that list again of things to look out for.
So symptoms are partial or loss of strength in an extremity, numbness, usually localized to an extremity. It might be your face though, so it could be your head extremity, I suppose. Loss of language ability, either understanding or speaking.
Wow.
Loss of vision, and usually it's not totally out of both eyes. Usually it's like partial, like sometimes tunnel vision. And if you have a risk factor, know your risk factors. Make sure your provider knows them. And don't wait around for it to go away in a couple of days, because that's going to guarantee that it'll either go on to something catastrophic or something permanent that makes your life a whole bunch of misery to try and deal with.
Right.
Yeah. So especially if it's a transient ischemic accident or a TIA, look at that as an opportunity to change something that needs to be changed quickly and make sure that some provider somewhere, mostly the ER, is able to address that. They'll likely, the first thing they do for somebody with stroke symptoms before they fly them out is they do a really quick CT scan of the head, and it's non-contrast CT, and they can tell whether somebody's bleeding there. Mm-hmm. And if they don't see bleeding in the brain, then they assume an ischemic stroke, and they'll fly you out to get the blood clotting. I don't think they do the reversal of the clot medicines here. Mm-hmm. I think they have to fly you out, but there's also the possibility of taking care of clots surgically. So there's a lot of different directions you could go, and it does need more tools than we have here.
Right.
But you can get some of the foundational care here,
mm-hmm.
and
mm-hmm.
it's so go to the ER.
Yeah.
You know?
No, that's good. That's a good tip, because it sounds like it is that quick response. That's what you need most right then, is to get into it right quickly.
And then if you've had the unfortunate experience of having a stroke, let's say it's an ischemic stroke, then take your blood thinning medicine, control your blood pressure, take your statin. If it's recommended that you have a carotid endarterectomy, that means like a roto-rooter of your carotid arteries. Do that, even though that itself can be a risk for stroke. Mm-hmm. There's a certain amount of bravery that you have to do to face that, and that the provider who's doing it needs to face too, I think.
Bravery based upon, an understanding of everything that's going into it.
Relative risk.
Right, exactly.
It's relative risk.
Yes.
So this could make me a lot worse, but there's only like a 1 in a million chance of that, or it could make me a lot better,
Yeah, and stave off something that you've got a greater than a 1 in a million chance of experiencing.
Right.
Yeah. Wow.
And if they tell you to stop smoking, stop smoking.
And I don't know who would tell you to start smoking, but yes, keep smoking. R.J. Reynolds, maybe Dr. Reynolds. Yeah. What do you? Yeah. Oh my gosh! Wow. Okay. Well, that's yeah. So I guess I'm It is. You were talking about. I'm intrigued by the fact you shared the insight of that. This is, you get a room full of doctors, and this is like, or healthcare people. This is scare
their
number
terror.
one. Right?
I'm going to take away their ability to talk.
Oh my God! Right.
Take away their cognitive ability. That would be shattering.
I was reading what you said as being just it's that suddenness of something, and then boom, you're altered and changed. But that's not what it is. It's the fact that it's actually affecting their intellect. It's affecting their brain.
They see themselves as sometimes they're more humble than this, but they see themselves as
gods.
Well-educated people who have something to bring to it, and they don't want to lose that.
Yeah.
My cognitive ability is the most important thing to me.
Sure.
If I lost the use of an arm, okay, that'd be a bummer, especially with my left arm, because I'm left-handed. But, or even part of my vision. Mm-hmm. But to me, to lose my cognitive ability is like, so that brings a whole bunch of different neurologic dilemmas into it. But Parkinson's, as far as we understand it now, is not preventable. Alzheimer's, as far as we understand it now, is not 100% preventable.
But
there are aspects of this that are completely preventable.
Right.
So we call those modifiable risk factors. So I can't change my gender. Women get more strokes than men. So I can't change that risk factor that I have. Mm-hmm. But I can take my statin and control my cholesterol. I don't really have a blood pressure problem. Let's say if I did, I would be all over the DASH diet. Doing what I can do to change things to prevent this, because this is really a terrible thing.
Yeah. Wow. Well, that was a very insightful. Any thoughts about next week's Health Matters?
Yeah, I'm excited to visit the pool as a way to exercise. Mm-hmm. So that might be a couple in the future, because there's exciting things going on down there. And also, I'm still interested in, now I'm kind of ways your brain could go bad.
Oh no.
So maybe that'll catch my eye this week.
All right. Well, Lynn Szabo, thank you very much, and we'll talk next week for the next Health Matters.
Yep.